Hello, happy Teach Me Tuesday. Coming to you this second week of February, where we are talking about congenital heart diseases and defects that we are experiencing in the NICU. I did wear a heart shirt for you, although this is technically my placenta shirt. And if you've been around for a minute, you may know about my love of the placenta. But the placenta is quite helpful with congenital heart diseases when the baby is still in utero. So felt like it's still kind of fit for today. Today we are talking about hypoplastic left heart or hypoplastic left heart syndrome or HLHS, whatever you want to call it. I'm going to talk about some resources that I have found to be really helpful with understanding this disease over the last, many years, and I will link them also in my Instagram stories so that you can see them for yourselves. But let's dive in. So hypoplastic left heart syndrome is a complex heart disease where the left side of the heart is underdeveloped. And when you think about normal heart function, that left ventricle and left aorta really do so much of the pumping. Aorta, left atrium. They are pumping the blood into the aorta. So if you remember, we've talked about how if you think about what color the aorta is, tells you what color the baby is. If we can't even get blood to the aorta, we're not getting blood to the baby. So this is a very critical congenital heart defect because it really can boldly affect the baby, right? The left side of the heart cannot pump that oxygen-rich blood to the body. It's like trying to receive it, but it can't receive it, and then it does receive it, and then it just doesn't have that muscle to get it out. So this combination of heart anomalies results in severe obstruction of blood flow from the heart. And then the right side of the heart has to work even harder to try to do the work of both sides, and it's going to get fill back on it. So let's break that down just a little further. In a normal heart, right? Normal pumping heart. I realize like my hands are backwards for you, so I'm like not doing this well. But the left side, so this is my left side, probably looks opposite to you, of the heart's job is to pump oxygenated blood into the aorta, right? You got to get this oxygenated blood up into the aorta. The mitral valve, which separates the two chambers of the heart, is too small or it is completely closed. So the mitral valve is in there. It can't really do its job. Sometimes it's closed, then the blood can't get through the chambers. That's not good. The left ventricle could be very small. The aortic valve, which separates the left ventricle from the aorta, is too small or closed. And that main pump, right, the left ventricle, when you hear that, that's that left ventricle pushing the blood up into the aorta. So in hypoplastic left heart, you can have one of these problems, you can have a combination of them, but the more you have, the worse obviously the baby is, and especially if that left ventricle is small. So CHOP is one of my favorite websites. So this is from CHOP's page, and I just think it's a beautiful diagram of kind of what is happening here. So in this hypoplastic left heart, we see this like underdeveloped aorta that really it's purple because we've talked about what kind of blood are we getting to the babies, mostly because a backup of the purple blood. In all honesty, this underdeveloped left ventricle with maybe a blocked aorta or an aortic valve here cannot get the blood up there. So all of this red oxygenated blood is backed up into the right side of the heart. So you can see we've got blue deoxygenated blood coming into the right side of the heart. We rely on this ASD PFO to be open between the two atrium to allow some oxygenated blood to get into the right ventricle. The right ventricle, as we know, dumps into the pulmonary arteries. But if this ductus arteriosus were to be closed, okay, so let's say this is like a little patch right here, you can see that we're not getting any oxygenated blood to the baby. And even so, we're getting poorly oxygenated blood to the body in the way that it's set up. So you can imagine how serious of a defect that this is. So the left side of the heart, which is the main pumper, If it's impaired, oxygenated blood can't get to the body. So this thing that we rely on to really push the blood up and out isn't doing its job. Blood's going to back up into the right side of the heart. It's going to back up into the lungs, and it can really make the baby quite sick. This is often diagnosed in utero, most of the time, especially the severe hypoplastic left hearts. If not diagnosed in utero, the baby may present with signs and symptoms, and then an echo is performed, and then of course an echo is a gold standard. In utero, a baby's probably getting a fetal echo, a fetal MRI of the heart, some more testing of the heart to see exactly what's going on. But those signs and symptoms that prevent after are going to be cyanosis, difficulty breathing, difficulty feeding, lethargy. Again, they're not going to pass their CCHD screening. They're going to have issues that say, hey, we need to investigate more. Hopefully we know about this ahead of time. And babies now, they will come to the NICU and we will right away work on keeping their PDA open. If you think back to that slide a couple slides ago, where without the PDA, we don't have any oxygenated blood getting to the body. It's really intense. And in fact, I have been a NICU nurse for 20 years now. In January, it was 20 years. And so 20 years ago, a lot of hypoplastic left heart babies did not survive. They didn't survive the delivery room. They didn't survive the initial hours after care. And they sometimes didn't make it till surgery. We're going to talk about how far we've come. But really, what is so key on this is that we are getting those prostaglandins started right away so that we can keep that PDA open. So that's having a protocol in place that you get PGE, alprostadil to your bedside when the baby is born. That you have someone ready to go, sterilely standing there to put in that UVC so we can get a line started and get the PGE started right away. We don't want any part of that PDA to be closing. We want the whole thing to be wide open, loosey-goosey, so that blood, that oxygenated blood, even though it's only partially oxygenated because it's still mixed with the deoxygenated blood, can get out to the body. So you need to have your experts available to get the UV in, and then we don't want to be giving the baby a lot of oxygen because that will promote more blood flow to the lungs, which will steal blood flow from the body and can even put more demands on that right ventricle. So when you think of a hypoplastic left heart, these are the kids that have a dedicated line nurse, a dedicated nurse, someone setting up fluids, a conversation with the pharmacy, whether that's a protocol in place, someone in the NICU putting in orders the minute the baby's born, having stat orders, knowing we're getting the baby, getting the prostaglandins out so that they can be drawn up right away. Whatever it might be, is having something available so that we can get that PG started right away. Because our goal then is, if you're not at a hospital that has open heart surgery where they are going to be cracking open the baby's chest, is to quickly transfer them somewhere that they can. Now, do they have surgery the day they are born? No. So if they're stable on their PGE, they're doing pretty well. Some babies will in turn stay in their NICU that they're born at until their mom can get discharged. So there's just going to kind of depend on what your protocols are and what kind of surgeries you do. But the surgical option for hypoplastic left heart is a 3-step process. First, we do that Norwood procedure, which again is happening in that first few days, first few weeks of life. Again, probably not the first day. There's a new aortic arch created, connects the hypoplastic area to the ascending aorta to the pulmonary arteries. It's going to close off that ductus arteriosus, enlarge the ASD so that there's more of that mixing, right? We saw where that unoxygenated and oxygenated blood were mixing and then going into the right ventricle, so that we can establish this stable circulation and have adequate blood flow to the body. So the baby has that. They typically recover for a period of time, likely not leaving the hospital. This is one of those diseases where the baby's in the hospital for an extended period of time. Then they go and have their Glenn procedure. That's usually when they're a few months old, they've stabilized, they've grown a little bit, and so now the surgeon's going to create a connection between the superior vena cava and the right pulmonary artery. So then the blood flow from the upper body bypasses the right ventricle, goes right into the pulmonary arteries so that it can just go and do all of its gas exchange, oxygen exchange. So then we're bypassing that right ventricle and getting the workload on that single ventricle decreasing so that the right ventricle really can just do the job of what the left ventricle usually is doing. We're improving oxygenation by allowing more efficient blood flow to the lungs. So we're getting the blood there that needs to go there. We're not getting oxygenated and oxygenated blood in there, so that we just kind of have that drainage system happening. So then the final procedure is the Fontan procedure. It's usually when the baby's 2 to 3 years old. And the inferior vena cava is also connected to the pulmonary arteries. So we have a complete separation of the systemic and the pulmonary circulations. That was nothing, right? No big deal. Just 3 procedures. I, again, am going to link some videos on my Instagram page to CHOP. CHOP has great videos that kind of go through all of this, explain it, show you what they're going to do. I really enjoy watching their videos, but great, much better than I am at explaining this. This is not something that I have experienced. I am not an experienced crack the chest cardiothoracic NICU nurse, or I guess cardiothoracic, CVICU, and pediatrics. I have only worked in level 4 NICUs that go up to ECMO and cracking the chest. So I know that this is a limitation of my practice. What I take away for this is really understanding what the parents are going to be going through and what this long-term outcome can be. Also reinforces back to me the importance of keeping that PDA open, because as a NICU nurse, that is going to be my primary job, is titrating my PGE, watching my oxygen saturations, keeping them in a low to normal oxygen saturation area so we're not giving them too much oxygen. The long-term outcomes of these babies, they do usually do pretty well right now. In this day and age, in 2024, we have much better outcomes. Of course, they're very high risk for developing cardiac complications later in life, including heart failure, arrhythmias, and valve problems. I even was reading in one article about how women that have, had hypoplastic left heart as a child can go on to have pregnancies, but that each pregnancy puts more stress on the heart. So they can have limited number of pregnancies, but I just thought that was kind of a cool thing to think about. You're not really thinking about that a baby is, this little baby's going to have a child one day, but lots of regular checkups with a cardiologist and a cardiothoracic surgeon to really optimize their cardiac function. For the parents is that most babies are going to qualify for surgery. Occasionally, the defect is too severe and a baby may be offered comfort care. This is a situation where maybe that there wasn't a big enough PDA, or the left ventricle and the aortic arch were so blocked, so small, that they just really, the baby wasn't getting much oxygen in utero. All these things were kind of going astray for the baby, and that they don't think that they would survive surgery, or the burden of survivability would be too high. So that is rare. Most of the time that these babies do have surgery, it is one of those situations, again, where the babies are in the hospital for a really long time. And when you go and you see all these stories, I've seen so many of them on Instagram and TikTok, and they're in the hospital for a long time. Many of them do well, but it does have, only 90% of them recover. So those other 10% are dying of their disease prior to full repair. Long-term management is going to include the cardiologist, a high-calorie nutrition, because you have this debate of fluid versus nutrition. So you have to have high-calorie nutrition so you can give the baby less fluid. Monitoring if symptoms of heart failure develop, having medication management. The baby's likely going to be on diuretics, blood pressure medication, and any other medications to try to offset that heart failure. So this was once a cardiac defect that had no known surgery or ability to treat. That when they started treating it, there was not a high survivability of the babies that underwent surgery. But now with advances in technology and surgery, these infants do actually do quite well. The prompt initiation of prostaglandins to prohibit the closing of the PDA is, if you take away one thing from this lecture, that's what it should be. Getting the PDA going to keep that duct open, because it is the only way that oxygenated blood is getting to vital organs. Again, we've talked about what happens with impaired circulation or impaired oxygenation to your other organs. You're at risk for liver failure, kidney failure. Even these babies can be at risk for neck, which we don't always think about. But when you have decreased perfusion to those vital organs, your gut is always going to be kind of one of the last ones. So think about what will happen there. Long term, these children are essentially functioning on one ventricle, one pump, one little pumping chamber going on. So close follow-up with the pediatricians, the cardiologists, the cardiothoracic surgeons, but these babies do go on to have amazing, wonderful lives. So I hope this helped understand your hypoplastic left heart syndrome. Again, I will link many of these resources onto my Instagram page. Thank you for joining me, and I will see you next Tuesday for our third week of heart defects and another defect for you. Have a great Tuesday.